And so she introduced me, and I met with them and talked to them, and it ended up being a good fit for both of us. And so I started working here. So that was really just by knowing the right person to ask.
Do you ever have so many questions and no one to ask, so they're just wasting away on Google searches you'll forget about in an hour or so?
We had that same problem, and that's why we created the RD2BE podcast, a resource for dietetic and nutrition students looking for answers that their peers don't have.
We are students Macy and Emily and registered dietitian Carl Barnes. We engage in conversations and learn from RDs.
Join us weekly as we gain insight into the unique journeys of registered dietitians all over the country.
Welcome back to another week of the RD2BE podcast. I'm your registered dietitian host, Carl Barnes. This is our weekly podcast where we sit down with a different registered dietitian each week to showcase the diversity of opportunity in the profession and really dismantle the notion that there is a traditional career path by showcasing the many different routes that your career can take at different times. Very excited to be sitting down with Dr. Krista Viau today. She's from the Food and Drug Administration. Thank you so much for spending time with us today, and we're looking forward to learning more about what you've done and what you do.
So hi, my name is Krista Viau. I am a metabolic dietitian. I started at the University of Utah, where I worked there for 8 years. During that time, I achieved my master's and my PhD. From there, I went to Boston Children's Hospital and continued in metabolism. And since then, I've actually moved again to the Washington, D.C. area, and now I work at the Food and Drug Administration. I'm not doing metabolism, but working still with infants.
Great. Well, thank you, Dr. Viau, for being here today. So when you were a metabolic dietitian, what did you do during that time?
So a metabolic dietitian is really someone who works with infants, children, and adults with inborn errors of metabolism. So these are inherited genetic conditions in which you have a change or mutation in your DNA, and so you do not properly metabolize a certain nutrient. I think the most common example would be, say, phenylketonuria or PKU. In that case, you do not make the enzyme phenylalanine hydroxylase, so you cannot convert phenylalanine into tyrosine, and that very simple change has devastating effects. Now, fortunately, PKU and over 50 other inborn errors in metabolism are caught on newborn screening. And so what happens is a baby's born, they have their heel pricked. If one of those tests is positive, many times they will call the metabolic clinic. And that's where the physician and the metabolic dietitian will often get involved. So I really think it's a very interesting area. It's a challenging area, which I think attracted me to it, because we have, these essential nutrients that we have to figure out, okay, how do we give just enough of that essential nutrient, assessing, the laboratory values, the clinical status of the patient, and the growth, because these are infants, to make sure that we are not causing iatrogenic nutrient deficiencies or other problems without causing, the negative sequelae of whatever condition, we are actually treating. So I think it's really an interesting area that you have to have a lot of problem solving skills, and really it's very clinically focused, where you are, routinely assessing all those parameters that I just said.
Sure. So I know you're obviously different from a pediatric dietitian, but what is the main difference, I guess?
It's a good question. So we are pediatric dietitians. I think one difference is that because these are inherited conditions, it's a chronic disease. So you're going to have it your entire life. And there are new therapies coming out like gene therapy and things, but that's another story. So in our clinic, we actually would treat infants, children, and adults. So because inborn errors of metabolism are quite rare, so in many centers or many states, there may only be one clinic. Now, you do have some states, say like Boston, for example, they have several clinics because it's a very, densely populated area. But when I started in Utah, they had one main clinic and then one very small clinic in southern Utah. So, we really have to treat everyone. So we do treat, like I said, the lifespan, but also, we're a pediatric dietitian, but we're a very specialized pediatric dietitian. So, when it comes to other conditions in pediatrics, I'm reaching out to my, my renal colleagues, my GI colleagues, But whenever, a metabolic patient is hospitalized, they are calling our team because everyone's a little bit afraid of our patients, which I would say, don't be afraid of our patients, but call us. I think it's really a fun area to be in.
I'm sure. So I know that you received your education at Utah State, and now you're in the DMV area. So what made you decide to move from Utah to like the DC, Maryland, Virginia area?
Sure. So that actually wasn't my choice. Like I said, I was working at the University of Utah, and actually I had just received a promotion. And so I really wasn't very keen to move at the time. I had a great position, but my husband's job moved him to Boston. And, even though I wasn't keen to move, it really worked out, I think, to my benefit. And I would encourage anyone that has the opportunity to try a different center, maybe within your same field, to do so, because you can learn a lot. But I was able to go to Boston Children's and work essentially in my same position in metabolism. And so I really think that improved my clinical skill set. I was able to learn from really fantastic dietitians, a whole new team of physicians, and it opened up opportunities that wouldn't have been available to me otherwise. So that was kind of that initial move. And then once again, the move was my husband's job over to the DMV area. And I think that that's opened up opportunities that, I hadn't had before. So I would encourage everyone to try something new if you can.
Most definitely. So kind of like you said earlier, this is such a niche field, right? So how did you get into it?
Oddly, I think I've always been interested in metabolism. I learned about it when I was shadowing dietitians in high school, and they mentioned PKU and how they talked about it, that it was a challenging area, and, that always kind of piqued my interest. And then when I was going through my coordinated program, we had our one lecture on inborn errors. And I reached out to the dietitian and said, hey, if you need anything, I'll do anything for free, and when I went to, do some education work for them, they happened to have an opening for a diet tech. And then that just opened the door, and I was able to get a job right out of college in this area, which is, something that I really wanted.
That's great. So since you have such a strong clinical love, what made you want to get your PhD in public health?
So I always knew that I wanted a terminal degree, and I am very interested in research and wanted to run my own studies. So that was part of the, the research background in the PhD. Public health specifically, I think so much of what we do is behavior-based. You can tell everyone all day to, quote unquote, eat a healthy diet, but you have to actually go out and do that. And so I've always been really interested in the psychology and, how to create and motivate people to actually achieve, these behavior changes that we're asking them to do. And so at first I looked into psychology, and that didn't seem like a good fit for me. And then I looked at the program in public health, and before I hadn't realized that they had such a heavy focus on behavior change. And so that was a good fit.
Of course. So what, I guess if you were to see yourself now when you were a dietetic student, what do you think you would say to yourself?
If I was a dietetic student looking at me now, so in that case, I think I would be happy with, where I've gone so far. I was always really interested in developing an expertise in a specific area. And that's something that I really tried to do. I'm still very early in my career, and who knows where, life will take us next. But I think I would be happy.
So would you mind talking about the process of getting a PhD and how long it is? What made you want to do the specific research you did?
Sure. So every program is a little different, and it was important to me to find a program that enabled me to work simultaneously, because I was already in the metabolism clinic. I knew that's what I wanted to do. I didn't want to take time out for, to just focus on a PhD. So that might be different for, for viewers out there. And it may be beneficial for you to just do the PhD program. But I decided to do both simultaneously, which was rough, I will say. So I did it in 4 years, But once again, I mean, PhD programs are incredibly variable depending on the type of research you're doing and the type of PhD you're getting. So you really can't say that, well, it's just going to be a 4-year program. But so the first 2 years of my program were really didactic. And so is, taking a lot of classes. We had several exams to qualify, for your PhD, and then you really focus on your dissertation. So for my dissertation, I wanted to do behavior change in metabolism. So I looked at motivational interviewing for patients with PKU to see if we had more frequent contact with them, if we use these motivational interviewing techniques, if we could motivate them to improve their what we call metabolic control, to see if we could reduce their blood phenylalanine levels and help them adhere to their diet more closely. And so that's something that I really wanted to do, which once again was how I chose my advisor, because I wanted someone who would support, this research idea that I had rather than me working on kind of their studies. But there are pros and cons to both. I mean, I think, working on a study that your advisor has already kind of established can be very beneficial. So I would definitely consider that if I were, looking at a PhD program now.
So what were the results of your findings, if you came across any?
Sure. So they weren't as dramatic as I wanted them to be. We did find that with more frequent contact, we improved self-efficacy. So people, thought they could do better, but we didn't really move the dial as far as the actual blood phenylalanine results. And so this was over a 6-month period. I still clinically very much believe in the more frequent contact, in the motivational interviewing, because these are chronic conditions, and you're working with kids their whole lives, and you just have to meet people where they're at. And that's just my personal belief and what's kind of worked for me clinically. But no, I wasn't able to show a dramatic change.
Okay. Well, that's still good that you still have in the back of your head that there probably is a correlation, even though it wasn't necessarily found in your population.
We'll keep trying. Yeah.
So I know you're a board certified pediatric dietitian. So do you need anything to be a metabolic dietitian?
No. And that's actually something that we are working on, because when, you can get a, board certified in pediatrics, which is great, and you certainly is needed, but, metabolism is even more specialized. Initially, our group went to the Academy of Nutrition and Dietetics, and there weren't enough of us to warrant creating this new certification. And I don't believe that the group has, approached A&D recently enough, but something that, we're considering of how do we help educate and make sure people are qualified to treat this population.
So you earlier said that you now work with the pediatric population at FDA, and you also worked with them up in Boston. So what made you want to work with the pediatric population opposed to older adults with these chronic conditions?
I think it's enjoyable to help people at such an early age. Kids are fun. And there's the added challenge of not only do I have to, meet the nutrient needs of whatever your condition is, but also in a growing child, whose needs are changing. And so all of those, I think, have attracted me to the population. And, because in metabolism, they're diagnosed at birth most of the time, not always. Many times, it just lends itself to the pediatric population as well. But it's really been a rewarding population to work with.
I'm sure. So for the children that have these metabolic conditions, do their parents have it as well? Or is it not hereditary or genetic?
It's a great question. So many of them are autosomal recessive conditions. And so the parents are carriers many times. And so, most people really have no idea that this is running in their family. And then it so happens to be running in, the other parent's family as well. We do have some that are X-linked or some that are dominant, but by far, most are recessive conditions.
You also mentioned that your husband moving to the DMV area is how you started your job at FDA, but what made you choose that job over a different position?
I got my job at FDA really through connections with other people. So when I found out I was moving, I reached out to my colleague at Children's National, who works in their metabolism program, and I said, hey, do you have a job? I'm coming to the area. And unfortunately, they weren't hiring at the time, but she knew of a fantastic team at the FDA. And so she introduced me, and I met with them and talked to them, and it ended up being a good fit for both of us. And so I started working here. So that was really just by knowing the right person to ask.
That's great. What do you do in your current role at FDA?
So I am on the infant formula and medical foods staff. So for infant formula in the United States, there is a pre-review or pre-market kind of review process. And so we will go through and see if there's anything that would make us concerned, that the infant formula wouldn't be safe. We want to make sure the infants are growing well on it, that the protein, in the formula seems to be bioavailable. We also look at specific ingredients to make sure that they're generally recognized as safe. We review, study protocols to make sure that if a company is going to be doing a study on a formula, that the protocol is sound and will actually, give the answers that we're looking for. So really, I kind of looked at it as well before I was, looking after these handful of kids, making sure that, they can grow and thrive. And now, we're kind of looking over the US population of infants who are consuming infant formula.
So the group you're working with is for, general population children. It isn't directly for those with inborn errors of metabolism.
Right. So now it's actually for both, because medical foods were really designed for inborn errors of metabolism. That definition isn't just inborn errors of metabolism, but it certainly was started out that way. But then we also look at, things, specialty formulas for infants with other conditions, for premature infants, for infants with GI conditions, et cetera.
Wow, that's great. What are some things, really valuable things that you've learned at your time in that position?
I think I've learned just how important it is to do these studies beforehand, and really to have that team that's looking over, all of those itty bitty details, and, making sure that everything is up to code when you think about so many different infants who are consuming these products, and making sure that, they're safe, doing our best to do so.
Definitely. And then I guess my final question is, what's the most rewarding part of your current job or jobs you've had in the past?
I really think it is the opportunity to help someone reach their full potential. Thinking about working directly with patients, it's really rewarding in metabolism because they're chronic conditions. We really treat the same people over and over. So we get the opportunity to know the families, to know the kids, to help them, meet life's challenges, to figure out how do I, treat this kind of, unfortunate chronic disease and still grow and thrive and live a happy life. So that's really been awesome. But also just in metabolism specifically, I'm thinking about, you're just such a valued member of the metabolic team, because the therapy for most of these conditions, the primary therapy is nutrition. So, the doctors are looking to you to come up with the treatment plan sometimes. And so it's a fun dynamic. And, I haven't worked in other areas professionally, so I can't say, if it's the same in renal or, different areas, but certainly in metabolism, it's been really fun to be a key valued member of the medical team.
Awesome. Well, thank you so much for taking time out to speak with us today. I appreciate it.
Thank you.